Well, discuss the clinical then and economic challenges that are typically associated with rare diseases across the board, Michelle.
It's not easy to do trials in rare diseases because the patients aren't all usually centered in one place, and especially in lupus, the disease is so complex that it's hard to have a patient population that is comparable. And that's led in lupus trials to the use of outcome measures which are never used in practice, such as the SLE responder index, which is a burdensome outcome to actually measure.
So that's a research tool, and if you see it, it's not designed to be on the clinician's desk every day.
Absolutely. The clinician, if I ask them what is the SRI responder index, would say they don't know. And I'm sure managed care felt the same way.
Has the environment and the outlook for rare diseases been changing, possibly as a consequence of the Orphan Drug Act or the Rare Diseases Act?
Well, I think in hemophilia, there's been, again, the advocacy on the part of patients and also the providers who take care of them. And in 1974, the federal government established a comprehensive network of hemophilia treatment centers across the country. Now there are about 130 of them. And those have also been centers of initiative to make sure that patients have access to the care they need in a comprehensive model. As well as the drugs that they need to stay healthy.
I mean, there's a whole bunch of people, right, that are impacted by this rare disease. One, of course, the person with the disease, and it must feel a little odd to be somebody with what we're going to call a rare disease, to be told by your doctor, congratulations, nobody's got this but you. And by the same token, how does a payer look at this saying, you've got a disease that is so unusual, it's going to cost us a fortune only for you, and everybody else can't have that money. How do you reconcile all of that?
Well, when you look at the budget impact, because these are rare diseases, that single patient may be high cost, but the total budget impact is very small. And so what do we do? Well, if there's a treatment that really can assist the patient with function, with quality of life, that's FDA approved, it may require prior authorization, but it's usually made available.
So do I really hear this right? That a payer is telling me, even though your disease is expensive, you're the only one, or very few of you out there, so go ahead, spend $10 million, we don't care. Is that what you just told me?
It's not that we don't care. That gets back to appropriate use. We do care. So we want to make sure that we derive the highest value from a high-cost therapy, and that also includes directing the patient to centers of excellence where they can derive the highest value from that care.
And
So,
I think if I could also
Patrick,
jump
yeah,
in,
I was just going to ask you. I knew you were going to jump in on this.
Yeah, and I think that's a great point that you bring up because you can't really be sure that patients with rare diseases are being treated appropriately unless they're being seen in centers of specialization. And believe it or not all patients have a hemophilia treatment center that's considered to be in their managed care providers network. But that's something that, in terms of advocacy, I'd like to see change so that all patients with hemophilia would be able to access care and services at hemophilia treatment centers.
But I want to go on to this guideline issue, because we heard that some of the guidelines really aren't. They're research tools. But is there a difference between clinical practice guidelines, let's say for hemophilia, but we could extend this to any rare disease, and managed care's concerns? If the guideline says do A, and managed care reimbursement says, maybe you shouldn't because it costs too much, where do we fall on this?
Well, I think it's a big discussion. One of the guidelines that's the most discussed in hemophilia is the guideline that young children with hemophilia beginning at an early age begin to receive regular infusions, preventative infusions of clotting factor concentrate, anywhere from twice a week to up to every other day. That's an expensive therapy, and it costs about $100,000 a year to administer it to a child with hemophilia. That's the guideline. We know that when we look at hemophilia treatment centers in the United States, only about 50% of them describe their patients as adhering to that guideline. And there are a number of reasons why that might be. Some of it might be adherence and compliance on the part of the patient. I think lots of times it actually is access. And it's issues such as insurance caps or lapses in insurance, et cetera. So I think definitely there's a role of managed care to help figure out how to provide the therapy, because we know that patients in the long run do better in terms of morbidity, reduced costs. They're productive members of society when they have access to clotting factor concentrate, for instance.
But does rarity factor in? In other words, I know you said it does in the sense that, well, there's not a lot of you guys out there. Let's say $100,000 a year, it's $1 million every 10 years, but there's not a lot of you. But is there any other factor that you weigh in terms of the rarity of the disease which affects your funding policies?
It's really identifying the right patient for the right therapy and then channeling them to the extent that these therapies are costly. How do we minimize waste? How do we make sure that we derive the highest value from these drugs that are so expensive? And frankly, you know, what's the worst that can happen is when you're paying for these therapies and the patient still ends up in the hospital with a bleed. That's the worst case scenario for a health plan that's paying for essentially high-cost drug that's not
Which is
being
why I think
delivered
you want those
appropriately.
patients, you know, seen in a specialized center where the person writing the prescriptions is paying attention to those factors and making sure that the prophylaxis is optimal. I agree.
But I think sometimes, for example, in lupus, the academic community isn't ready to tell you what the guidelines should be because we don't yet know. And often in lupus, the disease is so complex and so multi-organ that we're begging for flexibility.
And she's looking for certainty.
Yes.
Now that's a conflict, isn't it?
That's why we're seated next to each other.
I mean, is there ever a moment, by the way, when researchers and academics say, we better not write the guideline because it'll lock the payers in and we don't want that?
Well, I think you're going to find there are very few guidelines in lupus. Just recently we have some lupus nephritis guidelines, but even those guidelines are really uninformative about choices in the patients who don't respond to initial therapy.
Boy, that makes me feel great. Hugh, you were going to...
Well, I was going to add that with respect to guidelines, even though, as Marie mentioned, this disease states are probably not very prevalent. However, if we look at what happened in 2012, actually a little over a third of all pharmaceuticals that were approved by the FDA actually were approved under the orphan drug status. And there are about 1,700 additional products in current development, either in phase 2 or phase 3. So this is, while it may not be a big issue now, is it something that we're going to see very much in the very near future. And for managed care, what we need is, again, endpoints. Who should be on the medication? How long should they be on? When should you stop someone who is not responding? What's your definition of non-responder? Those are very critical points that we have to have in place in order to know how do we cover a certain medication or a certain therapy.
All right, well, before we leave this section, I just want to throw up another just enormous question. Clinicians versus patients. Expectations. Are there differences in expectations between clinicians who see these rare diseases and patients who have them? And if so, where's the common agreement points?
Well, I think it's up to the provider when giving say the parents of a child with hemophilia a diagnosis of hemophilia to sort of outline what life is going to look like going forward. And I think it's a big responsibility, but all members of the multidisciplinary team, nurses, social workers, et cetera, help make sure that patients and the people who are caring for them are on the same page with regard to their treatment. I think in hemophilia care, it is a little sad that many of our patients have begun to, or have really grown used to bleeds, and they really think that it's normal to have a bleeding event happen every 2 weeks, et cetera. When we
Did you
know,
just say every 2 weeks?
Yeah, and remember that when a bleed happens into a joint, it's dramatically disabling, and a person can't go to work. Mobility is limited. It's painful. It takes a big toll on the person's quality of life.
I can't get beyond every 2 weeks. That's a lot.
Well, if you think it's a lot, sometimes patients bleed more than that. But what I wanted to say was that those patients may think that that's normal because that's the way it's always been. It doesn't have to be that way. That's where giving the replacement medicine in a preventative fashion, if possible and if appropriate for that patient, can be so life-changing.